Hello, everyone. Thank you so much for joining us today. My name is Dr. Elaine Wan, and I am Associate Professor of Cardiology and Cardiac Electrophysiology at Columbia University. I am the Director of EP Research and Vice Chair of this writing committee for this AHA scientific statement focused on periprocedural management and multidisciplinary care pathways for patients with cardiac implantable electronic devices. And I am so grateful to be joined by the chairperson for this statement, which is Dr. AJ Rogers, and I'll allow him to introduce himself.
Hi, Elaine. I'm Dr. Rogers at Stanford University, one of the electrophysiologists and a physician scientist, and I had the distinct pleasure of joining you for this work on the perioperative care of patients with CIEDs.
Thank you so much, AJ. And I just want to take this opportunity to thank the American Heart Association for giving this opportunity to us and our entire writing committee, which was composed of experts in electrophysiology, cardiology, anesthesiology, as well as nursing practices to help us form this important statement. And when we do a statement, usually we question why do it and why do it now. And I wanted to explain that the inspiration for this particular scientific statement was basically a dedication to all the practitioners that interact with patients with cardiac implantable devices. Since the last American Heart Association expert consensus statement with the Heart Rhythm Society and the American Society of Anesthesiology was published in Heart Rhythm in 2011, there have been rapid technological advancements in implantable devices, and so much so that there are more devices implanted in patients more than ever. And we do different things now with advanced technology. Specifically, the devices are placed including pacemakers, defibrillators, loop recorders, leadless pacemakers, subcutaneous, as well as extravascular devices. We wanted to take this opportunity to discuss the management of these devices during a range of procedures, including during MRI imaging, surgery to radiotherapy. And with the advent of the leadless pacemakers into our community and into our patients, we thought that this paper was timely. And this scientific statement was imperative to update the various clinical communities that interact with these devices and to provide a framework as to how to perform periprocedural management of the patients. And here we outline the planning phase, procedural phase, and subsequent care post-procedural workflow. And as I mentioned before, it was very important for us to establish a multidisciplinary writing group that would appraise the current evidence and offer management work strategies that would be of clinical use to the different academic as well as clinical practices. There's a tremendous gap in healthcare ranging from radiology imaging, which is necessary to identify these devices, as well as to nurses and other providers on how to care for these patients with these devices while they're undergoing outpatients or inpatient procedures. So the purpose of this statement really was to maximize dissemination of this information and the advances in electrophysiology on these devices now being put into our patients and how to manage them during the various procedures. So I will allow Dr. Rogers now to talk about the main points that we presented in this statement.
Thank you so much, Elaine. So as Elaine said, it really takes a team in order to get patients safely through an operative procedure if they have a CIED. And so we tried to encapsulate this life cycle in the central illustration where the patient goes from the CIED care center or their kind of primary physician managing their device, usually a cardiologist or an electrophysiologist. And that life cycle goes all the way through pre-procedural planning, where the care is customized based on the specific procedure that they're having and the device that they have in their body. It goes through the intra-procedural portion, where monitoring and emergency management of the device and for hemodynamics occurs. And then post-procedurally, where we very importantly restore settings to the most appropriate settings, either what was there before the case, if nothing has changed in the cardiac hemodynamics, or new settings if we've significantly altered something about the patient. And then finally getting that information back to the CIED care center so that appropriate follow-up and planning can be performed. The figure that we presented in the first section of the article is really geared towards creating a kind of a straightforward workflow for people in the perioperative setting to have the information they need to take good care of the patient. What we endeavored to do here in the first figure is to create a pathway that is accessible. It's relatively straightforward, and it covers 99% of patients going through care. So I'll quickly go through that here. It's meant to be short. So first of all, if the surgical site and the electrical return pad are below the lower half of the body, the chance of electromagnetic interference is actually quite low. And as long as the device is not in the abdomen, you can proceed with the surgical procedure without a high risk of interference. Next, we decide, is the device a defibrillator or is it not? And the reason this is important is because with defibrillators, the magnet cannot affect the pacing mode, whereas the magnet can affect the pacing mode for most pacemakers. And so this is an important early step to decide. If the defibrillator is there, the next step is to disable ICD therapies through the magnet if no adjustment to the pacing is required. But if the pacing to adjustments are required, then that should be done through programming. Next, if the patient is pacing dependent, the device should be put into an asynchronous pacing mode so that electromagnetic interference will not cause inhibition of pacing. And once those are done, proceeding with the surgery is the next step. And finally, we want to make sure that reprogramming the device after the procedure is always performed before the patient leaves and tachytherapies are re-enabled, for example. We have a magnet checklist. If you're planning on using a magnet, then appropriate patient position during the procedure is important. Not all positions, such as prone, are compatible with using a magnet on the chest. The magnet has to be not in the sterile field. We want to make sure that the magnet mode activates preoperatively, especially in the case of leadless pacemakers, where it can be difficult to localize the device with the magnet. And some leadless pacemakers may not have a magnet mode. And if there is an ICD, then just a reminder that the magnet does not affect the pacing mode. And importantly, to talk about how to determine what type of device is in the body, the next figure that we share goes through the different device types. First, panel A showing how to determine between a transvenous ICD versus a pacemaker, focusing on the coil. That's typically on the right ventricle lead. And then panels B, C, D, and E show some of the new devices that have come out since the last guidelines were written by the HRS and anesthesia and AHA groups. Leadless pacemakers, the panel B, and dual chamber leadless pacemaker on panel C, the subcutaneous ICD in panel D, and the extravascular ICD in panel E. And then finally, loop recorders are more and more seen here, and we've provided examples of each of the different manufacturers since they have slightly different form factors. We provided a couple of tables for people to reference with respect to sources of electromagnetic interference with different types of procedures, with some general rules, tips, and tricks, things to look out for, and then mitigation strategies. Finally, a table on magnet response for the different types of devices, since this is something that is a quick reference and would be good to know for your specific patient and device manufacturing. Finally, we tried to touch on the interdisciplinary care of CIEDs and how this hospital workflow can be put together into a quality care pathway. We recommend that every center spend some time working between the different stakeholders to make sure that patients move through this process safely and efficiently. And again, thanks so much to all of our co-authors who have a ton of experience in the fields of nursing, anesthesia, cardiology, electrophysiology, and even a couple of trainees that really dedicated a lot of time and effort to this work.
Thank you so much, AJ, for walking us through this paper, and really a great applause and compliments to the whole entire writing group for preparing such a comprehensive statement that you and I were so lucky to chair together. So I just wanted to talk a little bit about the methodology and how we approached this. So first, we identified the gaps in understanding since the last statement, which was in 2011, and we assembled a writing group that really included all the multidisciplinary expertise that was necessary. And we performed a series of different literature reviews to really identify the relevant literature that has occurred over the last decade as to the advancement of the new devices in electrophysiology. We then really took our time to assemble these into easy to understand figures, workflows, and tables that we thought would really allow for efficient referencing and also adaptation into different clinical practices. So I wanted to once again reference, for example, all the images and radiographs of different devices. So for example, if a radiologist was trying to see what type of devices this patient have, we gave them a selection of the different devices that might be found on routine imaging. And then I wanted to really briefly go over the key takeaways from this statement, so to really highlight what you can learn from this comprehensive statement. First of all, just as AJ talked about, it's really important to develop interdisciplinary communication with the CIED team before the procedure, notifying the device team about the upcoming procedure, and facilitate generation of a plan. Post-procedural communication with the teams about the device and whether or not there was any changes or reprogramming that was done, and to ensure that when the patient leaves the facility, that there is safety and safe continuity of care. And I think I wanted to highlight two scenarios. One, pacemaker-dependent patients, that electromagnetic interference can occur due to cautery or other issues that might lead to oversensing inhibition of pacing, especially when surgery is performed above the umbilicus, except for patients with devices in the abdomen. We also wanted to highlight that with the advent of the leadless pacemakers, to know that magnet responses may not be effective in all devices. For example, the Medtronic Micra leadless pacemaker does not have a programmed response to a magnet and therefore needs reprogramming. Emergency magnet use can be used in addition to reprogramming as described, and may be used in certain scenarios, for example, avoiding inappropriate shocks and defibrillators. And also the important thing is that in patients with defibrillators, to avoid inappropriate therapies, the detection can be programmed off, or if it's not available, reprogramming to place the magnet on the pulse generator. So I think highlighting these different devices which are now available to our patients and are already being placed and have been increasingly placed as the patient population ages and there are more heart disease, it is important for all healthcare providers to be aware of the different devices which are currently available and what sort of periprocedural management needs to be done. Finally, I wanted to join AJ in thanking the writing committee, which really put a lot of time and effort and thought into trying to make the paper into something that is easy to read, adaptable to different clinical scenarios, and really comprehensive. So once again, please let your institution and your colleagues who deal with devices and patients know about this paper. And on behalf of the writing committee and of the American Heart Association, thank you so much for your time and enjoy the reading.